topic is endocrine disorders. The endocrine system is the hormone system of the body. So what that word endocrine means is that's a chemical messenger that is produced in one part of the body but has effects elsewhere in the body. So there are other kinds of crins. You know, there's paracrine, which is local to local. There's exocrine, which is a secretion, so like into the digestive tract or out onto the skin. Those are exocrine secretion. Endocrine secretions are into the bloodstream for an effect at a distant site. So most of what we're going to talk about today is diabetes, because that's the single, probably, or at least clinically the most important of the endocrine disorders. So we're going to spend most of our time on that. And then we're going to briefly cover some of the other hormone derangements. But they all sort of fall into the same, or they all have the same characteristics. So in endocrine disorders, you can either have too much hormone, too little hormone, or not enough hormone effect. So either the body is producing too much, it's producing too little, or for whatever reason, there's an effect problem, you know, like a blocked receptor or the absence of a receptor. In other words, the hormone level is fine, but the body's response to that hormone is altered somehow. So hormone levels can get too high for a couple of reasons. Tumors, it's strange, but cancer has a tendency to produce active substances like hormones. Now, you wouldn't think that this tumor cell, as screwed up as it is able to, you know, to do anything that's going to affect the body. But they do, in fact, produce hormones. Some tumors produce estrogen, others produce antidiuretic hormone, some produce epinephrine or norepinephrine, which you can imagine would be a major problem. So tumors can produce excess hormone levels, and because they're tumors, they're not regulated by the hormone control system. So things can really get out of whack. In liver failure or kidney failure, hormone levels can be too high because they're not being removed. You know, it's the liver's job and the kidney's job to remove hormones from the bloodstream all the time. If they're not removed, they just stay around. And as long as those hormones are around, they're going to continue to create those hormone effects. So we can see that. And then in some congenital conditions, we just have overproduction of a hormone. So Cushing's syndrome, for example, is a problem with the adrenal gland where it just produces much too much glucocorticoid or cortisol, which we'll talk more about at the end of today. So that's excess. In deficit, it may be that there's not enough hormone being produced, or that for whatever reason that hormone isn't creating the effect that it's supposed to. You know, we see that in type 2 diabetes. It's not that the patient doesn't produce insulin, because they do. It's that the insulin they produce can't generate enough effect to solve the high glucose problem. So a deficit situation can either be, again, a tumor in an endocrine gland, like the thyroid gland, can reduce hormone production. If there's an antagonist that's present, you know, say in the calcium system, for example, you know, you have parathyroid hormone and calcitriol. Well, if either one of those is out of whack, it's going to have a tendency to fight the effects of the other. So you can get kind of an imbalance. Malnutrition can lead to a number of hormone deficits. And then obviously surgical removal of a gland is going to cause a hormone problem because there's no gland to produce it. We used to see this in thyroid disease. The patient would have their thyroid gland removed, and along with that, they'd lose their parathyroid glands too, so they'd have calcium problems. Now that surgery has gotten better, we don't see this as often unless that gland has been removed on purpose because it had a tumor in it or was out of whack somehow. All right, so common blood tests across all of the endocrine disorders. In the modern laboratory, we can check the levels of most of the hormones in our body, even the ones that are rarely looked at. So in the modern day, it's immunoassays are done. So antibodies are used to detect the level of hormones in the plasma. So that's the most common thing that's done today. Urine tests for hormone. Probably the most common one is HCG. That's the hormone of pregnancy. Can be detected in the urine very early on because the tests that we have are very, very sensitive for that. And you can test for other hormones in the urine in that same way. We can do stimulation or suppression tests. Most hormones are affected by other hormones. That's how the body sort of controls this chemical messenger system, is with other hormones. So like if we're testing the thyroid gland, for example, we can give thyroid-releasing hormone and see if the gland responds. So it's part of the diagnosis of where in that endocrine system is the problem. Is it at the thyroid gland, or is it at the hypothalamus, or above that in the system? We can take pictures. A gland that is larger than it's supposed to be is usually one that has a problem. Either it's producing too much hormone, or it's missing something so it can't produce as much as it needs, like in the case of a thyroid goiter that we'll talk about later. And then if need be, if we're worried about a tumor, we're going to do a biopsy, because that's always the gold standard for diagnosis of any kind of tumor. The treatment for many endocrine disorders is replacement therapy. Again, in the modern day pharmaceutical business, we can produce just about all of the hormones that our bodies produce. And if we give the exact same molecule, it's going to have the exact same effect. So like we see this in insulin, which used to be harvested from cows and now is created by fancy bacteria that we've engineered for that purpose. Thyroid hormone is another we very regularly give people as a replacement therapy. So replacement therapy is a big part of endocrine treatment. Excessive secretion is a little harder to deal with. We can always give somebody the hormones that they need. Now, taking them out is a lot harder. So, there are medications that can block the release of certain hormones. Surgery, we can take the gland out. If it continues to produce excess hormones, we can remove it or we can destroy it. And this is actually done in the treatment of certain thyroid disorders. The thyroid gland is either completely or partially destroyed, or completely or partially resected to lower that hormone production that's causing all the symptoms for the patient. So the most common endocrine illness that we see in our everyday patient population is diabetes. So there's two types. There's type 1 and type 2. But both of them have the same common endocrine dysfunction, and that is absent or inadequate insulin. So a little review of insulin. Insulin controls the transport of glucose from the blood into cells. So one way to think of it is insulin opens the glucose doors. If insulin is present, glucose flows into cells. Once it gets into those cells, the cells can use that glucose as fuel. Glucose is a primary fuel molecule. It's not really good for much else, but it's the principal source of ATP for a lot of the cells in our body. In the absence of insulin, regardless of how high the blood sugar is, the insulin cannot get into the cells. So you end up with this very strange situation where you have a ton of nutrient around, glucose, but it can't be used by anything because it can't get into the cells where it's utilized. So that's sort of the common pathophysiology of both types of diabetes, is the absence of insulin means that the body is glucose starved. Even though the blood sugars are 400 or whatever, because that glucose can't get into cells, it can't do any good. Now, there are a few tissues in the body that can utilize glucose from the blood even when insulin is absent. So the central nervous system and skeletal muscle are the two primary ones, but the kidney will do this as well, and the myocardium, so the heart. So these are organs that are relatively spared in a diabetes situation. The CNS can use glucose even without insulin. So the problem with the brain in glucose management is when the sugar gets too low. Because while the brain can use glucose without insulin, it can't make glucose, so it has to be present in the bloodstream. So from that common pathophysiology, we have two very different diseases. You know, type 1 and type 2 diabetes have a different cause, even though they share a common pathophysiology. So in type 1 diabetes, the beta cells in the pancreas, which are the producers of insulin, end up being destroyed. Now, why? We don't exactly know. You know, a lot of research goes on today trying to figure out what causes type 1 diabetes. We know what happens, and that is the immune system destroys the beta cells of the pancreas, and therefore there's no insulin production in the body. So in type 1 diabetes, they are insulin dependent. So one of the classifiers is type 1 we call insulin dependent diabetes mellitus. Type 2, insulin is still being produced, so the patients don't require insulin from the outside. Now, sometimes insulin replacement is used in the type 2 diabetic, but in the type 1, it is necessary because there's no production. So it usually occurs in children and adolescents, although it can occur in adults, but that's pretty rare. It's usually acute in onset. In other words, the child had no prior problems and then presents to an emergency room with a very high blood sugar and a diabetic ketoacidosis, which we'll talk about later. Not linked to obesity. Type 2 diabetes is very much linked to obesity because it has a lot to do with insulin resistance, or having so much adipose tissue that the pancreas can't produce enough insulin to get that blood sugar down. We think there are some genetic factors that play a role. You know, if you have a person with type 1 diabetes in your family, you're more likely to see additional cases in that same genetic family, but it's not like a single gene disorder. It's something you're not born with, but that occurs sometime in childhood. All right. So in type 2, it's non-insulin dependent. Their beta cells in the pancreas are just fine and produce insulin, sometimes not enough. So in type 2, there's this whole other range of treatment options that we call oral hyperglycemic medications. And these are medicines which either improve the effectiveness of insulin at cells or allow more insulin to be released. So either they improve the effectiveness or they improve the secretion of insulin. So in type 2 diabetes, the root problem is either a decrease in insulin production or an increase in insulin resistance or insulin requirement. You know, at some point, the pancreas can only produce so much insulin. So if the body needs more insulin than the pancreas can produce, you're going to end up with a type 2 diabetes picture. So here the onset is usually slow and insidious. It affects patients over age 50, although this age is dropping all the time. We're seeing more and more type 2 diabetes in younger and younger patients. That's part of the obesity in America problem. So we're seeing type 2 diabetes earlier. It's part of that metabolic syndrome that we talked about in our adolescent chapter, you know, where you have high lipids, obesity, high blood pressure, and then type 2 diabetes goes along with that too. All right. Yeah?
Can you explain how the body becomes resistant?
We don't exactly know. But one theory is adipose tissue has lots of insulin receptors. So if you have a lot of adipose tissue, you have a lot of receptors to fill. So essentially the pancreas can't produce enough insulin to fill all those receptors and the receptors in all the rest of the body. That's the theory.
Okay, so what's the fat doing with the glucose? Wanting to store it?
Yes, yes. Adipose tissue turns glucose into triglyceride for storage.
It's the fat before it's going to the needed.
Yes, yes, exactly. So in both type 1 and type 2, you have some common symptoms. Polyphagia, that's hungry all the time, and fatigue. Both of those come from the relative starvation that's going on in the cells. Because glucose can't get into the cells, it can't be used. So cells all over the body are sending out signals that there's not enough nutrition. You know, there's not enough nutrients. So patients stay hungry all the time. They're tired because, you know, the body is sort of working in a starvation mode, even though there's plenty of glucose around. We see hyperglycemia in both type 1 and type 2. Typically, that's how the diagnosis is made. With sugar in the urine is usually the initial finding. You should never find glucose in the urine. It's always abnormal. So if you find glucose in the urine, it means the patient is hyperglycemic, because you don't start to see that until your glucose levels are above like 250. Excess glucose in the urine, we call that glucosuria. And glucose in large concentrations behaves just like salt does. So if you have a lot of glucose in your urine, osmosis is going to pull water from your body into the urine to try to balance out that concentration. So you end up with patients who pee a lot and pee often. So polyuria and polydipsia, and that is a direct chemical result of the glucosuria, which is a result of the hyperglycemia. So those three things sort of go together. High blood sugars means lots of sugar in the urine, which means lots of water in the urine, so we get polyuria and polydipsia. Now, dehydration can actually occur in diabetes because the patient can't drink enough to keep up with their urine output. So we end up with this hyperosmolar state, which we'll talk more about in a minute. All right. So diagnosing diabetes is pretty simple. You know, you get a urinalysis or you get a Chem 7 or a Chem 8 that has a high glucose, and this is the next step. You do a fasting blood glucose level. In a patient who hasn't eaten in a while, their blood sugar should be about 80, you know, between 60 to 80. And that's the liver keeping the glucose level at a bare minimum. If you have somebody who hasn't eaten for 12 hours and their blood glucose is very high, that is diagnostic of diabetes. It's just that simple. If your blood sugar is greater than 150 at a fasting point, then in fact you have diabetes. Some other tests, if that's inconclusive, a glucose tolerance test is where you start with a fasting glucose and then you give the patient a known quantity of pure glucose, and then you measure their glucose levels over the next several hours. Now, what you should see is a relatively stable glucose level, because in the normal person, blood sugars don't really rise and fall very much. The liver sort of keeps them locked in between 80 and 100, or 120. In the patient with borderline diabetes, that glucose tolerance test is positive. In other words, you give them glucose and their blood sugars go way up instead of being stable. And then a relatively new test that's in very common use is called the hemoglobin A1C, which I know many of you have heard of, and that's a glycosylated hemoglobin. In the presence of high glucose levels, that hemoglobin protein ends up getting sugar stuck to it. And when you have lots of hemoglobin with sugars attached, that's a signal that glucose levels have been elevated for several months at least. So it's a long-term measure of blood glucose, is the hemoglobin A1C, or the glycosylated hemoglobin. So the overall treatment principles for diabetes are to keep blood glucose levels in the normal range. Now they've gotten very serious about this. You know, if you had looked at the treatment of diabetes 10 years ago, people were happy if blood sugars were below 250, you know, but now we want to see blood sugars in the normal range, so in that 80 to 120 range. So diabetes is being treated much more carefully, and the reason for that is all the research shows that the complications of diabetes are a direct result of high blood glucose levels. So if we keep the patient's blood glucose in the normal range, we can avoid those potentially fatal complications like atherosclerosis, like diabetic kidney failure, like microvascular disease that causes diabetic ulcers and things like that. So we tight glucose control, diet and exercise. Exercise alone helps to reduce blood glucose levels because the skeletal muscle can grab it all by itself. So skeletal muscle doesn't need insulin to utilize glucose. So the more energy you can get your muscles to burn, the lower your blood glucose gets to be, even without insulin being present. So patients who are trying to take very good care of themselves will be on a strict exercise regimen so that they can burn up that glucose using skeletal muscle. Then we have some oral medications that help to decrease glucose levels or increase insulin secretion. And then, of course, there's insulin replacement. There's no such thing as oral insulin. It always has to be delivered in another way. Usually it's delivered subcutaneously. You know, patients would have a hard time delivering a medication IV, you know, because you'd have to find a vein every time. So instead, insulin is usually given sub-Q, and that's because it's easy for patients to do that. The problem is they do have to stick themselves, although the technology is getting better and better on that all the time. All right, so some differences. Type 1 diabetes, lots of metabolic changes. This is a complete blockade of the glucose system. In other words, no insulin means glucose can't get into cells except for those exceptions, like the CNS and skeletal muscle. So in the absence of glucose in those cells, they still need energy. So they have to shift to other forms of energy. So they burn fats and proteins. Now what we see metabolically is we see ketones in the blood. Ketones are released by the liver as well as some other cells as sort of a backup energy source, because most cells except for the brain can use ketones to create ATP. So when fats are broken down or proteins are broken down, ketones are usually what's released, and then the cells can get those because they're not involved in insulin. We also see high levels of fatty acids in the blood too, as the body tries to use fats to supply its needs in the absence of glucose in the cells. Because we have ketones in the blood, we end up with ketonuria. This is another urine test that's diagnostic for diabetes. Ketones in the urine are either diabetes or starvation. In other words, people haven't had enough to eat in a while. So you have to ask about their diet on that point. Left untreated, type 1 diabetes will result in DKA, diabetic ketoacidosis. These ketones are acids, so they have a tendency to lower the pH of the blood. If you have lots of ketones, you're going to have a very low pH, so you're going to be acidotic. And we talked a little bit about how acidosis is bad for you. You know, even a pH of 7 as opposed to 7.4 is a patient who is significantly sick. So left untreated, we get into a decompensated metabolic acidosis that's called DKA, or diabetic ketoacidosis. And we'll talk more about that here in a little bit. So in type 1 diabetes, the complications, really this is both type 1 and type 2, are directly related to those abnormal glucose levels. So in the type 1 diabetic, you know, you'd think it would be easy to just give the right amount of insulin. Well, it's not, because what we eat changes from day to day. Our activity level changes from day to day. You have illness that happens and affects, you know, your metabolic needs. So type 1 diabetes can be a real bear to control. You know, most type 1 diabetics are testing their blood sugars 3 or 4 times a day, sometimes as little as 2 in the very stable patient. But because of all these variations, you have to test and then decide how much insulin you're going to give yourself based on, you know, your eating patterns and based on your blood sugar. So it requires a lot of patient education. You know, those of you that are going to go on and become nurse educators, this is one big field for nurse education, because the diabetic patient has so much self-care to learn about, and it's not all simple. You know, some of it is some relatively complex physiology. All right. So the acute complications of type 1, hypoglycemia. In patients who are receiving insulin for therapy, too much insulin will drop your blood sugar. Too low of a blood sugar, and you can get significant CNS deficit. You can get unconsciousness. You can get coma out of that. So that's what we call insulin shock, because the patients lose consciousness, their blood pressure starts to drop. It looks very much like shock, and it's because of a lack of adequate blood sugar. So its cause is excess insulin in the circulation, causes a glucose deficit, which can eventually lead to brain damage or even death if not corrected. So it can be from dosing errors, strenuous exercise that's surprising. The patient encounters some emergency where they end up doing a lot of skeletal muscle activity and they weren't expecting to. That can drop your blood glucose levels. Vomiting, skipping meals. People who are type 1 diabetic have to really be careful, not only with the insulin they give, but also with their eating habits. They need to be consistent. You can't give insulin unless you're going to have something to eat, or your blood sugars will drop. So this just goes over the mechanisms of hypoglycemic shock. So too much insulin, all the insulin goes into cells. That causes hypoglycemia. So you get a CNS breakdown. The brain can only use glucose. So when the blood sugar falls, the brain is the first thing that's affected. All right. So some signs and symptoms. Disorientation. This one, and I added a word here. It's because patients who are in hypoglycemic shock can seem drunk, and they sometimes are mistreated and not identified properly in emergency rooms because people think that they're intoxicated, and that is what has messed up their blood glucose levels, and not, in fact, that they're in hypoglycemic shock. So this is a medical emergency. Any patient who is a type 1 diabetic or a type 2 diabetic who's using insulin, this should be at the top of your list of things to rule out because it can be fatal, and it's relatively easy to fix. How do you fix hypoglycemic shock? You give glucose, and most diabetics will carry either a glucose tablet or a little glucose solution bottle that they can drink in a hurry to elevate their blood sugar if they start seeing any of these symptoms. The experienced diabetic can tell when their blood sugar is dropping because they get diaphoretic, they get anxious, they get hungry, and they know that, okay, my insulin was a little too high and I need to take in some extra sugar. All right. The most dangerous complication of type 1 diabetes is this one, diabetic ketoacidosis, or DKA. Now, you can see DKA in the type 2 diabetic, and you see it more and more, probably because there are more and more type 2 diabetics. But it used to be that if it was DKA, that was almost diagnostic for type 1. Not true anymore. So you'll see a difference in literature about this as when you read different books. This has changed, essentially. So no longer is DKA only type 1. We see it in both type 2, but it's much more common in type 1. The problem here is insufficient insulin. So insufficient insulin makes for high blood glucose levels. And the real cause of the ketoacidosis is not the glucose levels, it's the absence of glucose inside the cells. So because of this relative starvation that's occurring, the body produces tons of keto acids in an effort to supply the body with energy. Those keto acids lower the pH and throw the patient into a metabolic acidosis. So there are lots of things that can trigger a DKA event, things like illness, infection, alcohol intake, exercise, all the same things that can cause a hypoglycemic shock can also cause a DKA. And DKA can occur pretty rapidly. Patient can be normal and by the end of the day be in significant diabetic ketoacidosis, particularly if they have been skipping insulin injections. So the pathophysiology here, there's a couple of different parts. So no insulin means no glucose transport into cells. So we get alternative energy uses. So lipolysis releases ketone bodies. Ketone bodies are acids. So we get a ketoacidosis and we get ketonuria. So we get ketones in the urine. That leads to an acidosis, which is one of the principal diagnostic findings in DKA. Their pH is too low. In addition, hyperglycemia causes glucosuria, which causes polyuria, and polydipsia, which causes dehydration. All that glucose going into the urine pulls water with it. And this is dehydration in the face of acidosis is like a double whammy, because dehydration also has a tendency to lower pH because of poor perfusion. So when you add these two things together, you get a very sick patient because they're acidotic from the ketone bodies and they're acidotic from the poor perfusion of dehydration. So that's when you start getting into a shocky looking picture. You know, patients with low blood pressure, low heart rates, sort of at death's door because they have this dehydration together with acidosis. And then in addition, electrolyte imbalance usually goes with DKA too, particularly with potassium. Potassium ends up being low in the diabetic patient who's undergoing DKA. All right, so signs and symptoms. The dehydration, you know, you can sort of divide it up into the primary characteristics. So we get dehydration, so we have a dry patient. So warm, dry skin, they're thirsty, they're dry, their oral mucosa is rough, like you'd see in dehydration. A classic symptom is rapid, deep respirations. We call these Kussmaul respirations. And in the patient who is lying in the bed relaxing, they'll be breathing like they've been exercising. So they'll be taking big breaths in, big breaths out. And their breath will smell kind of fruity. You know, acetone is the primary component of nail polish remover. And you'll walk in the room and you'll sort of smell this strange smell. And what you're smelling is the keto acids are volatilizing. So they're actually breathing out acetone, and you can smell that. So it's typically referred to as a fruity smell. The reason for the respiration change, the body controls the respiratory rate and depth based on pH. So a pH decrease for any reason will trigger an increase in respirations. Because usually the reason your pH is low is because you're not breathing off enough CO2. So the body, you know, the brain is saying, all right, the CO2 is too high, so breathe faster. Well, in DKA, it doesn't work because you can't breathe off the keto acids. So you have this rapid, deep respiration, but it doesn't work to increase the pH to normal. But it's a classic sign for DKA, Kussmaul respirations. On blood tests, you see a metabolic acidosis. So you see a pH that's low. You see a bicarbonate that is also too low. And then you'll also see electrolyte imbalances, particularly with potassium, but also with sodium and calcium. So classic symptoms of DKA. Now, in the type 2 diabetic, not only can they get DKA and hypoglycemic shock, but they can also get this disorder, HHNK. So hyperglycemic, their blood sugar is high. Hyperosmolar, their blood and their urine are hypertonic, so all that sugar is pulling water out of the tissues and pulling water out of the body. Non-ketotic, so this is the different part. In non-ketosis, the reason the type 2 diabetic doesn't get that is they are getting glucose into their cells. The blood glucose is too high. The system has been overwhelmed. So they're not in that starvation state, but they're in this hyperglycemic, hyperosmolar state. So it can result in cognitive impairment because of severe dehydration. Essentially, water is being sucked out of the cells of the body, including the brain, and being peed out, being made into urine. So the cells are losing water, so they're shrinking, and electrolyte imbalances are occurring as that water pulls electrolytes with it on its way out of the body. So HHNK we see exclusively in the type 2 diabetic. But it can look very similar to a DKA, you just don't see the acidosis. So you have the hyperosmolar dehydration problem, but you don't have the acidosis that goes with all those ketones. So in HHNK we see hyperglycemia, severe dehydration, and electrolyte imbalances, and then the things that go along with those. So anytime you have severe dehydration, your hematocrit will be high, your heart rate and respirations will be high as the body's trying to circulate oxygen in a decreased amount of plasma volume. All right. In type 1 and type 2, type 1 diabetes is usually pretty well controlled because the patients start out as children controlling the illness. In type 2 diabetes, it's harder to get adults to change their patterns and to take care of themselves. So you end up with many more chronic complications in type 2 diabetes because of poor control. And here's another thing that's changed. You know, it used to be that we were all taught that diabetes is a blood sugar problem. Well, now what everybody is being taught is that diabetes is a vascular problem. All of the chronic complications of type 1 and type 2 diabetes have to do with changes to the vessels. So it's a whole new way of thinking about diabetes. Now, the cause is still the high blood sugar. But it turns out that when blood sugars are high over the long term, it affects the vasculature. So you have a hugely increased incidence of atherosclerosis. So we end up with clots and thrombi and thromboemboli. We get these changes in both small and large arteries. And then in diabetes, you have this thing called microangiopathy. Atherosclerosis affects macroscopic vessels, you know, vessels that you can see with the naked eye. Diabetes also affects the microvasculature. So these are like your arterioles and your capillaries. And changes there cause tissue necrosis. Basically, it's like little tiny clots. So you end up with tissue that dies because of a lack of blood supply, but you can't see it. You know, it's happening sort of all over the body at once. So the classic complications there of the microangiopathy are neuropathy. So you lose sensation, and that's because it's the small vessels that supply the nerves. No blood supply, no working nerves. Retinopathy. The retina is supplied by these microvessels. So the retina literally dies with uncontrolled diabetes. It's diabetic blindness, and it's a leading cause of blindness in this country, and it's 100% preventable. You know, if we had patients who were taking good care of themselves, we wouldn't have that. But high blood sugars lead to microangiopathy and retinopathy. And then finally, chronic renal failure. Many of the patients you see on dialysis got there because they didn't control their diabetes. And this microangiopathy destroys the kidney slowly over time. All right. So this table just compares the macroangiopathy and the microangiopathy effects, but we're not going to go into all that. Here's what it does to the kidney. You know, a kidney is supposed to be kidney-shaped, and it should have a nice sort of smooth, shiny appearance. This is all rough and sclerosed. This kidney, this is called diabetic nephrosclerosis, and it results from that microangiopathy. Remember, the nephron is really driven by arterioles and capillaries, right? In the glomerular, or the corpuscle, where you have that glomerulus. So if you destroy those tiny little vessels, you destroy the kidney, because the kidney can't function without those vessels. So that's what happens in diabetic nephrosclerosis. Macroangiopathy, all the same effects of atherosclerosis. So heart attacks, strokes, peripheral vascular disease. You get this sort of strange combination in diabetes we call the diabetic foot. The neuropathy and the atherosclerosis and peripheral vascular disease together create this particularly nasty combo, because the poor circulation in the feet causes the skin to break down and the subcutaneous tissues to break down. But because of the neuropathy, the patients don't feel that. So they don't feel the pain of their skin breaking down on their feet. So you can end up with, this is a small one, but this is a classic diabetic foot ulcer. And what's happened here is the poor circulation from the atherosclerosis has necrosed this weight-bearing area of the foot, you know, because it has pressure on it all the time. So that skin falls apart, and the patient doesn't feel it because they have neuropathy. They can't really feel much of their feet anyway. So these can go on for weeks or months or even years without patients seeking any kind of care. So essentially, you can end up necrosing your entire foot, and these get infected, which you can imagine makes the damage worse. So many of the patients you see with amputations, you know, in 60-plus years of age, again, it's usually from diabetic neuropathy together with diabetic peripheral vascular disease. They lose integrity in the skin of their feet. So these are very hard to treat. Those of you who are going to go into wound care will get to treat many a diabetic foot. So this is a neuropathic ulcer. All right. People with diabetes are at increased risk of infection. You know, those of you who have taken micro, which is probably most of you, have learned that, you know, bacteria sort of like sugar, right? You know, it's good for them and helps them to divide very easily. So if you have high blood sugars, you are just a setup for bacterial infection because essentially you're a walking growth medium. So patients who have diabetes have more infections and they're more severe. And not only bacterial infections, but fungal infections too. Anything that raises your glucose level increases your risk for bacterial and yeast infections because they can feed on that glucose. You know, the yeast that makes, you know, beer and wine use sugar to make that happen. So they eat both things, fungal infections, particularly nasty fungal infections in diabetics. Periodontal disease, same thing. Bacteria in the mouth love glucose, and when they metabolize glucose, they create acid, and that acid eats away at the gums and eats away at the teeth. So this is periodontal disease in a diabetic, not pretty to look at. All right. Some others, cataracts, increased risk of that. In pregnancy, the woman with high blood glucose levels is at increased risk for a number of things. The common board question is increased size and weight. So babies of diabetic mothers have a tendency to be giant. You know, the babies that you hear about, you know, that were 18, 20, 22 pounds, they're infants of diabetic mothers, IDMs we call them. And that's because here's this baby who's developing, and there's all this glucose around. So they can just sock on the pounds and sock on the fat because there's all this glucose to use, because mom isn't using it because she's insulin deficient. And that's fine, you know, okay, we can deliver a giant baby, but they're not out of the woods yet, you know, because they're used to this huge amount of glucose being around. When suddenly they find themselves on their own without mom's high glucose level, their glucose level drops because all the while they were in the uterus, they've been churning out insulin to keep their own blood sugar normal. So their their pancreas has been hyperactive in insulin production. So when you take the baby out of the mom, the glucose stays with mom, and now suddenly the baby has all this insulin but no glucose supply. So their glucose levels drop. And these infants are usually kept in the ICU because they need very careful glucose management and glucose control. So we have to tailor their IV fluids to their blood sugar levels, so they can be a real challenge. Now, thankfully, infants recover from this quite quickly. You know, usually 2 or 3 days at the most, and their glucose levels have stabilized all by themselves. So the pancreas turns down, but it takes some time to do that. All right. So this is just a review of the potential complications, which we've covered already. All right. So in type 1 diabetes, you know, it's all insulin glucose management. In other words, you control what the patient eats, and you control the amount of insulin that's injected, the type and the when, or the time, the type and the time, to keep their blood glucose levels normal. In type 2 diabetes, there's some other options. So changes in diet, a reduction in lipids and simple carbohydrates helps to reduce the glucose flow coming into the patient. That can lower blood glucose levels. A high fiber diet also helps to decrease blood glucose. Regular exercise, you could add weight loss to this because current theory is that extra adipose tissue only makes the problem worse. Many patients, if they actually can lose the weight, which is hard in diabetes because you're in that metabolic syndrome, but if you can, you can correct. In other words, you cannot have diabetes anymore because you've fixed the problem. So, it is in here, reducing BMI or reducing weight. So exercise, diet, and weight loss. Those are the first 3 things you do with the type 2 diabetic. We monitor blood glucose levels in the type 2 diabetics so we can know what's going on with them. There are medicines that stimulate the beta cells in the pancreas to produce more insulin. And then if that doesn't work, then we can give insulin exogenously until maybe the diet, exercise, and weight loss has happened. Okay. All right, so our first questions of the day. All right, I have the student number question up. 5, 6, 7, 8, 9, 10, 11, and 2 of you still need to answer. Anybody not playing? Okay, I got everybody written down anyway. All right, there we go. Okay. And I'm going to move ahead because we got some other stuff to cover still. Okay. So, I'm using a new question source, so you're going to see some different kinds of questions. All right, a nurse is discussing endocrine system dysfunction with a patient. Which statement indicates the patient understood? Endocrine system dysfunction can result from hyposecretion, hypersecretion, or which of those other things? It's like a race. There's 2 answers, neck and neck. All right, anybody else want to jump in there? All right, there's my 10. So hypersecretion and hyposecretion is going to create B, abnormal hormone levels. So that's not it. Instead, the third thing that can happen is abnormal receptor activity. So your hormone levels can be normal, but the organ is not responding to those hormone levels in an appropriate way. So we would say A would be the correct answer there. All right, a 55-year-old is admitted to the medical unit for complications of long-term, poorly controlled type 2 DM. Which of the following would the nurse expect to find in addition to elevated glucose? Oh, all right, there's my 10. Oh, now I got 11. Correct answer there is A, atherosclerosis. So when you think uncontrolled type 2 diabetes, think metabolic syndrome. So you're going to have obesity, atherosclerosis, and hypertension. That's metabolic syndrome. So now atherosclerosis leads to a lot of the things we associate with type 2 diabetes, like peripheral vascular disease and the diabetic foot. But that is, in fact, caused by atherosclerosis. Yes?
You might want to answer this now or later, I don't know. We need to monitor the blood glucose level in the blood and also sort of like in the cells. So in the blood...
We can't do the second one. All we can do is look at the blood glucose level in the plasma.
It's important in the blood because of the brain and the muscle needed, or also because the osmotic balance?
In a patient with a normal blood sugar, glucose doesn't play a major osmosis role.
Okay.
Its osmolarity is irrelevant. It's only when it gets very, very high, like 700, 800, that it starts to be an osmolar player.
So it's mainly just for brain and muscle?
Yes, yes, yes. All right, we're going to skip this next one. All right, so that whole thing was diabetes, probably the single most important endocrine disorder in terms of clinical understanding. So the rest of it is just some little things about some other sort of scattered illnesses. So calcium is controlled by an endocrine system. And calcium is a sort of mission-critical ion. Calcium is necessary for nerve function. It's necessary for muscle function, heart function, and the clotting system. So you have to have a calcium that's in the normal range. So the hormones that play against each other, calcitonin causes calcium levels to go down. and parathyroid hormone causes calcium levels to go up. So these two sort of work in opposition to each other, and together they maintain a normal calcium level. Okay? So the feedback mechanism here from the parathyroid hormone part is if your calcium level drops, parathyroid hormone secretion goes up. That triggers release of calcium from bone. It triggers reabsorption of calcium at the kidney, so less calcium is lost, and then an increase in calcium absorption from the intestine. Many of the foods we eat contain calcium. So if all that calcium came into the body, we could have calcium levels that were all over the map. So parathyroid hormone actually controls the gateway of calcium into the body, and that's at the GI tract. So together, these three increases in calcium raise calcium levels. That is a negative feedback, so it turns the parathyroid hormone level down, and then the calcium levels stabilize. And calcitonin sort of works in the opposite direction. When calcium levels are high, calcium is stored up in the bone, it's not absorbed from the intestine, and then its reabsorption in the kidney is blocked so that the calcium can end up in the urine and reduce those calcium levels. So if parathyroid hormone is a calcium controller, we have our classic endocrine two versions. We have hypoparathyroidism, not enough, and we have hyperparathyroidism. So if your parathyroid hormone is too low, your calcium level is too low, and you get the classic signs of hypocalcemia. So weak heart contractions, increased excitability of the nerves, and increased irritability of the skeletal muscle. So you get things like tetany, you get stiff muscles, you get weak heart contractions, and you get paresthesias, nerves sort of firing when they shouldn't. So the causes here, a tumor, either in the thyroid gland or in the parathyroid gland, can block normal secretion. Any surgery or radiation of the thyroid gland to fix a thyroid problem can trigger this, can trigger a parathyroid problem. We've tried to get better about that, about trying to save the parathyroid glands when they do thyroid surgery. And then there are some autoimmune diseases that destroy the parathyroid glands preferentially. So in those patients, we have to give them parathyroid hormone in order to keep their calcium levels up. The hyper version, we get hypercalcemia, not surprising. So we get bounding, too forceful cardiac contractions. We get osteoporosis. Now, why is that? Because when parathyroid hormone is high, calcium is released from the bone, right, to try to elevate calcium levels. So if your parathyroid levels are too high, essentially your bones get weaker and weaker as the calcium is leached out of them. So it can be a cause of secondary osteoporosis. And then kidney stones. Why? Because when parathyroid is high, lots of calcium ends up in the urine. Calcium can combine with lots of different things to precipitate and make stones. So that's the classic three of hyperparathyroidism. The causes here, a parathyroid tumor or another kind of tumor that's releasing parathyroid hormone. Lung cancers are infamous for this. They have a tendency to create active parathyroid hormone that's not under any kind of control. So you get lytic lesions in the bones. The calcium is basically ripped out of them. And that's what we call paraneoplastic syndrome, is where a tumor is secreting parathyroid hormone. Okay. The pituitary gland is responsible for lots of different hormone production. The gender hormones like estrogen, progesterone, and testosterone are controlled by the pituitary gland. The one we see come up most often, though, is growth hormone. Growth hormone is responsible for linear growth, so height, essentially. So we have dwarfism, that's a deficit. Gigantism, that's an excess. If we have an excess that occurs after the bones have closed, so after the epiphyseal plates have closed, you can't get taller because your bones have stopped stop growing. But growth hormone still has an effect, and we call that should be acro, not agro. It should be acromegaly. And in acromegaly, bones get heavier and bigger, even though they don't get longer. So you get patients, well, I don't have a picture, but you get patients with large feet and hands and very pronounced facial features. So you know those statues on Easter Island? People start to look like that under the influence of excessive growth hormones. So their face bones get big and heavy, so they end up with very pronounced, very sort of bony-looking faces, which you can kind of see in this guy right here, but I don't have a close-up. So here is gigantism, so growth hormone excess. Here's dwarfism, growth hormone deficit. Both of these would be pituitary problems. Now, what are the common causes? Tumors are the big one. So if you have a tumor that produces growth hormone, well, you're going to have gigantism if you had that tumor when you were a child. If you have a tumor that blocks the normal, in other words, it's dysfunctional, then you'll have too little growth hormone and you'll get dwarfism. Now, in the modern day family practice and pediatric practice, we follow heights very carefully. And if it looks like we have a patient who is not growing tall enough, we'll send them to an endocrinologist because growth hormone can be given from the outside. And a patient who would have been, the next Tom Thumb, so to speak, can be made at a normal height through exogenous growth hormone. All right. So that's pituitary, growth hormone. ADH, hopefully you remember that ADH is important in fluid and electrolyte balance. It controls the release of water into the urine. So we all know that a diuretic makes you pee, right? So an antidiuretic does the opposite. It reabsorbs, or it triggers the reabsorption of water in the kidney, so you make a smaller amount of urine that's more concentrated. So you hold on to the water. Common theme, there's an excess state and a deficient state. So in the deficient ADH, not enough ADH, it gets a special name. We call that diabetes insipidus. And I forget what the root is, but diabetes has something to do with that word, means lots of urine production. So in diabetes mellitus, that's urine production from high glucose levels. Diabetes insipidus is a high urine output because of a deficit in ADH, or antidiuretic hormone. So what you get is you get the patient who is polyuric and polydipsic, so they pee a lot and they drink a lot. And it's usually because of a problem in what we call the neurohypophysis. So ADH is a strange hormone because it's actually produced by neurons, not by a gland. So anything that stresses or damages the brain can trigger an ADH problem, either an excess in the case of diabetes insipidus, or a deficit in the case of DI, or an excess in SIADH, which we're going to talk about in a minute. So head injury or surgery, some people are born with this. They don't produce ADH, or their ADH doesn't work. In other words, at the kidney it doesn't function properly. So we have to give it as a replacement. ADH we can give by mouth. It also comes in a nasal spray and a sublingual version. So we can replace ADH in patients that have diabetes insipidus. The excess we call SIADH, syndrome of inappropriate ADH secretion. Commonly associated with head trauma. What's the classic board question? Somebody who's had a head injury and their urine output drops, their urine becomes very concentrated, and they're thirsty all the time. So that's the classic SIADH picture. So the treatment there is diuretics. Some diuretics work on the same system as the ADH system does. And then sodium supplements. Now, how does that work? If you give somebody extra sodium, that has a tendency to pull water into the urine when the patient is overhydrated. So those two things sort of work together to draw water into the urine so that the patient's osmolarity stays normal and they don't end up fluid overloaded. All right, and then the last set is the thyroid disorders. Of the endocrine disorders we've talked about, diabetes is the most common. Thyroid disorders would be the second most common. What are you going to see in the history of your patients or in the current treatment of your patients? Diabetes and thyroid are the two most common endocrine disorders that come up. So first is the goiter, which we don't really see in this country anymore. But a goiter is an enlargement of the thyroid gland because of some problem in the production of thyroid hormone. Thyroid hormone requires iodine to be produced. Now, iodine, if I had a periodic table in here, I could show you. It's in the same family of elements as like chlorine and fluorine, so it's iodine. And it is found in small concentrations in seafood and in material that's come from the ocean. So, in the ancient past, most human beings lived near the ocean, and they ate fish as a regular part of their diet. Well, as human beings moved inland, they moved away from their source of iodine, which is the ocean. Iodine, or thyroid hormone, is one of the few things in the body that requires iodine to be produced. So endemic goiter happens in areas that are far from the ocean that have low iodine levels in the minerals in the water. So in the absence of iodine, the thyroid gland gets bigger and bigger trying to answer the call for thyroid hormone, but it can't answer that call because there's no iodine to make thyroid hormone with. So it gets bigger and bigger, and you start getting a patient that looks like this. So, the thyroid gland is in the neck, and basically the neck swells up in the front. You still see this in some parts of the world. You don't see it in America because one of the few things I think our federal government ever did well is they decided to start adding iodine to salt. So like when you go to the store and you buy table salt, it'll say iodized, and that means that iodine has been added to it so that us folks in the Midwest don't end up looking like this lady. So it's an iodine supplementation. So that's the most common goiter. There are two other kinds. Toxic goiter happens when the thyroid gland is out of control. In other words, normally the thyroid is controlled by the hypothalamus. If it escapes that control, it just produces more and more thyroid hormone, and it gets bigger and bigger and bigger, and the patient ends up in the excess state, so in the hyperthyroid state. And then there are a few goitrogens. We're not going to talk about that. All right. So the two, excess and insufficient. So hyperthyroidism, which is also called Graves' disease, or hyperthyroidism is too high a thyroid hormone for any level or for any cause. One common cause of that is Graves' disease, which is an autoimmune disorder. But these symptoms here are all symptoms of hyperthyroidism. And it's a good list to learn because thyroid comes up clinically so often, and it appears on board exams and stuff. So, the thyroid hormone is sort of the overall speed switch of the body. So when thyroid levels are high, metabolism is high, body temperature is high, people are running hot. It's like a car that's tuned a little wrong, and it's running hot and fast. So you have heat intolerance. Patients can't stand it when it's warm. They sweat. Their skin and hair get very soft and thin, from hypermetabolism. They get skinnier and skinnier. Some people try to use thyroid hormone replacement as a way to lose weight. Not a good idea. That can kill you. Insomnia. They can't slow down because their thyroid has got the body all revved up. And then they're hyperactive. So Graves' disease, we see this in. Toxic goiter, we see this in. So Graves' disease is a specific disorder where an antibody is actually triggering the thyroid receptors. So we end up in Graves' disease. If you ever see this picture or something like it, this is called exophthalmos, and it's the result of Graves' disease. So if hyperthyroidism speeds you up, this lady looks like she's about to explode, right? So this is Graves' disease or hyperthyroidism. This usually goes away when the thyroid problem is fixed, but it doesn't always. Some people end up looking like olive oil for the rest of their life. All right. So that's the excess. In the deficit effect, we get just the opposite. So, yes?
I'm sorry, doesn't it have something to do, I don't know if I just didn't see it, but doesn't it change like the color of your skin and makes you like tan or something?
Hyperthyroidism, you're thinking of Addison's disease. Mela something. Yeah. Yeah, you're thinking of Addison's disease. And it's from a side, it's ACTH also affects the melanocytes. So yeah. And I don't think we're going to get to Addison's and Cushing's today.
Addison's disease like an undersecretion of
Cortisol. Yeah. Addison's and Cushing go with cortisol. So Cushing's is too much cortisol, so you get hypertension, immune deficiency. Addison's disease is not enough cortisol. You got it. Yep, the adrenal cortex from the outside of it. And so in hypothyroid, if your thyroid levels are too low, you get the opposite problem. The body's running too cold. So you get cold intolerance, you get weight gain, lethargy, fatigue. You know, the body is barely on, so to speak. A number of different causes. That iodine deficit we see in other countries. Hashimoto's is an autoimmune disorder that destroys the thyroid gland. Anytime we treat the thyroid gland, like say you have hyperthyroidism and we take part of your thyroid gland out, well, there's no possible way to make that perfect. So people have a tendency to end up a little hypothyroid and have to take some thyroid replacement. The whole word for hypothyroidism is cretinism. This happens in the child. So the child who doesn't have adequate thyroid hormone ends up short with severe cognitive deficits. Thyroid levels are part of the state screen. You know, we stick the babies and we put little blood drops on a little card that we send to the state. One of the things they're testing for is thyroid levels, because if the thyroid level is low and it goes untreated, we end up with cretinism. But it's hugely treatable. You know, we can give patients thyroid hormone. So it's one of those very treatable congenital defects which can be fixed. So we also follow moms, the pregnant mother's thyroid levels too, because when thyroid levels are too low, the babies end up starting this process even before delivery. So thyroid gland and normal development through pediatrics is necessary. You have to have thyroid gland to develop normally. All right. So a couple of adrenal things. The adrenal medulla is the epinephrine, norepinephrine, adrenaline part of the adrenal gland. You can get a tumor there. So the pheochromocytoma is a tumor, usually benign, that secretes epinephrine or norepinephrine. Now, given what you know about the autonomic nervous system, having a tumor that secretes epi is probably going to be bad for you, right? You know, your blood pressure is going to be high, your heart rate's going to be high, you're going to be all hopped up all the time. So in the new presentation of hypertension, particularly in the young, we go pheo hunting. So we want to make sure that it's not a pheochromocytoma that's causing it. What we do is we collect urine for 24 hours and we send it for the metabolites of epinephrine and norepinephrine. All right. And then Cushing's and Addison. So Cushing's syndrome is excess glucocorticoids, particularly cortisol. It can result from anything that makes that happen. So an adrenal tumor, a pituitary tumor, a carcinoma. Sometimes carcinomas produce cortisol. Substance abuse. The classic Cushing's syndrome, it has an appearance, which is why we have this silly picture here. So you have a face that's very round. You have significant truncal obesity. You have thin skin and impaired wound healing because cortisol triggers those things. Now, we see this most often today because we did it. You know, we treat so many illnesses with glucocorticoids, autoimmune disorders, that one of the reasons that we try to limit steroid use is to prevent Cushing's syndrome, because you get this appearance, but then you also get a number of other bad things. So retention of sodium in water, immune system suppression, emotional lability. Cortisol tends to make people irritable. Remember, it's a fight or flight hormone, so you're not going to be particularly nice on high doses of cortisol. Delayed healing, and then insulin resistance, as well as catabolism of bone and protein. So Cushing can either be from the inside or from the outside. So long-term use of corticosteroids will result in Cushing syndrome. And then in Addison's disease, it's the opposite. Not enough cortisol, so you see the absence of a stress response. So like your blood glucose levels tend to be low. You can have problems with hypotension and low blood volume, weight loss, frequent infections. Remember, steroids have a tendency to build the patient up. Like this guy has been too built up, not in the good way, but in the fat way. And in Addison's disease, we have the opposite problem. You're very catabolic. You're burning yourself up, essentially. All right, and that's it. We did get through it all today, just not the questions. All right, so that is it for the day because we are out of time.